Bismillahirrahmanirrahim. Quote of the day, you never lose. You either win or you learn. I am Dr. Alishba Rasool, PGR Community Medicine, and today we will be doing a critical appraisal of an article under the supervision of Professor Dr. Saira Afzal. The article that I will be critically appraising is Social Skills Training for Children and Adolescents with Autism Spectrum Disorder, a randomized controlled trial. For this article, as it is a randomized controlled trial, we will be using the CONSORT checklist. Here is the checklist. Abstract. Social skill group training for children and adolescents with autism spectrum disorder is widely applied, but effectiveness in real-world practice has not yet properly evaluated. This study sought to bridge this gap. Method. This 12-week pragmatic randomized controlled trial of compared to standard care alone was conducted at 13 child and adolescent psychiatry outpatient units in Sweden. 12 sessions of manualized social skill group training were delivered by regular clinical staff. Participants were children and adolescents aged 8 to 17 years with ASD without intellectual disability. The primary outcome was the social responsiveness scale rating by parents and blinded teachers. Secondary outcomes included parent and teacher rated adaptive behaviors, trainer rated global functioning and clinical severity, and self-reported child and caregiver stress. Assessments were made at baseline, post-treatment, and 3-month follow-up. Moderated analysis were conducted for age and gender. Results. Significant treatment effects on the primary outcome were limited to parent ratings for the adolescent subgroup. Secondary outcomes indicated moderate effects on adaptive functioning and clinical severity. Conclusion. Social skill group training for children and adolescents with ASD in regular mental health services is feasible and safe. However, the modest and inconsistent effects underscore the importance of continued efforts to improve the social skill groups training beyond current standards. Clinical trial registration information, social skill group training for children and adolescents with high functioning autism spectrum disorder were given. Introduction. The prevalence of autism spectrum disorder is about 1% among children and adolescents in high-income countries. ASD affects several areas of social and adaptive functioning and is associated with an elevated risk of peer conflicts and societal exclusion. The present pragmatic multi-center trial sought to evaluate the effectiveness of the social skill group training contact delivered by the regular clinical staff as a complement to standard care. Participants in the present trial were representative of the heterogeneous group of children and adolescents with ASD admitted to regular mental health service in whom neurodevelopmental and psychiatric comorbidity is commonplace. The primary study hypothesis was that SSGT as a complement to standard care would be superior to standard care only. A secondary aim was to explore the moderating effect of age and gender. This, to our knowledge, is the largest randomized trial of the SSGT to date and the first to evaluate effectiveness in a diverse sample of the male and female children and adolescents in routine practice settings. Methods. Study design. This was a 12-week multi-center parallel group randomized pragmatic clinical trial that included 296 youth aged 8 to 17 years with ASD. Study participants. Eligible participants were children and adolescents with a clinical consensus international classification of disease, 10th revision diagnosis of autism, atypical autism, Asperger's syndrome, or pervasive developmental disorder, not otherwise specified. The diagnosis was corroborated by ASD cutoffs met on the Autism Diagnostic Observation Schedule 15, which was conducted by examiners clinically trained in ADOS. Intervention. Social skill group training, contact 8, draft English version and the material available upon request from the corresponding author is a manualized structured program for children and adolescents with ASD in the normative IQ range. The coordinating center randomly assigned eligible participants to SSGT or standard care using block randomization in a 1-to-1 ratio, applying computer-generated random numbers stratified within site and age group. Outcome measures. Change in total raw scores on the parent and teacher reported social responsiveness scale served as the primary outcome measure. Secondary outcome measures were parent and blinded teacher ratings on the adaptive behavior assessment system, the trainer rated developmental disabilities modification of the Children's Global Assessment Scale, Ohio State University Global Severity Scale for Autism, parental self-ratings on the perceived stress scale, and children's adolescent self-ratings on the Children in Stress scale. Sample size calculation. Sample size calculation to test the superiority of the SSGT compared to standard care alone was based on medium effect sizes found in previous pilot studies of the CONTACT. A sample size of 144 participants per group was required to provide 80% power at a two-sided 5% level and 5% attrition. Analysis were performed for the total sample and stratified by age group and gender, males and female. Statistical analysis. Primary and secondary analysis were conducted according to the intention to treat principles, including all randomized participants for whom data were available at baseline. Mixed effect linear modeling, random regression, which uses all available data in longitudinal study design and can handle missing data, was used to provide unbiased treatment effects. The model was specified by using time, treatment group, SSGT per standard care versus standard care, and the time by group interaction as fixed effects, with a random intercept for each participant. Results. Primary outcome measure. Parent rated SRS total score decreased for both treatment groups from baseline to post-treatment care. SSGT 87.9 to 78.7, standard care 87.9 to 81.8, treatment effect 3.1, 95% confidence interval 147.2 to 0.9. Follow-up and treatment effect 3.8, 95% confidence interval 8.1 to 0.4, but no significant group difference was found. Secondary outcome measures. SSGT was superior to standard care alone on secondary parent-rated outcomes of the adaptive behavior on the ABAS2, 10.7, 95% confidence interval 1.5 to 19.8, and parental stress reductions on the PSS. P is less than 0.01 at follow-up. Moreover, trainer ratings indicated significantly greater improvement from baseline to follow-up in the social skill group training group in the global functioning on the DDGAS and clinical severity on the ASU autism CGIS. Discussion. The study is the largest randomized trial of the social skill group training to date and the first to evaluate its effectiveness in the routine care. We demonstrate a small to moderate added value of the social skill group training in terms of improvements on ratings of autism-related symptomatology and adaptive functioning compared to standard care, although the effect on the primary outcome was limited to adolescent and females and was observed only by the unblinded parent. To maximize generalizability of the results and to demonstrate applicability in clinical practice, this pragmatic trial aimed for heterogeneity in several aspects. No fewer than 50 clinicians from 13 regular care units were involved in delivering the intervention. The study population comprised children and adolescents with ASD who were typically admitted to mental health services. Some study limitations should be noted. First, the validity of the teacher ratings was undermined by an unsatisfactory response rate. As a consequence, our conclusions are based on unblinded ratings, although we cannot rule out the possibility that the estimated effects to some extent reflect bias. The inconsistent results across measures and subgroups are not readily explained by bias. We conclude that for adolescents, especially females, a 12-week social skill group training was superior to standard care alone, with small to moderate positive effects on the social responsiveness, general clinical severity, and adaptive functioning. For children, on the other hand, significant gains were observed on secondary outcomes only. However, further efforts to improve the training are needed to move beyond the current standard. Awaiting more research on how the training should be optimized for different subgroups, clinicians are advised to adhere to the manual, but may continue training with an increasing degree of tailoring after completion of the 12-week program. Now we will apply the CONSORT checklist. Title and abstract, identification as a randomized trial in the title. It gives a structured summary of the trial design, methods, results, and conclusions. Introduction gives the scientific background and explanation of the rationale, gives the specific objective or hypothesis. Methods gives the description of the trial design, which is parallel, gives the eligibility criteria of the participants, gives the settings and locations where the data was collected, gives the intervention for each group with sufficient details to allow replication, including how and when they were actually administered, gives completely defined pre-specified primary and secondary outcome measures, including how and when they were assessed, describes how the sample size was determined, gives the method used to generate the random allocation sequence, gives the type of randomization, details of any restriction such as blocking and block size, gives the mechanism used to implement the random allocation sequence, describes who generated the random allocation sequence, who enrolled the participants, and who assigned participants to intervention, described who was blinded after the assignment to intervention, which were the teachers, gives statistical methods used to compare groups for primary and secondary outcome. It does not describe any additional adjusted analysis or subgroup analysis. Results for each group gives the number of participants who were randomly assigned, received intended treatment, and were analyzed for primary outcome through a flow diagram. For each group, does not mention the losses and exclusion after randomization together with the reason. Mention dates defining the periods of recruitment and follow-up. A table showing baseline demographic and clinical characteristics for each group. For each group, gives the number of participants denominators including in each analysis and whether the analysis was by original assigned groups. For each primary and secondary outcome, give results for each group and the estimated effect size and its precision, such as 95% confidence interval. Gives all important harms or unintended effects in each group. Discussion. Mention trial limitation, addressing sources of potential bias, imprecision and multiplicity of the analysis, gives generalizability, external validity and applicability of the trial findings. Mentions the interpretation consistent with the result, balancing benefits and harms, and considering other relevant evidence. Other information gives the clinical trial registration information, gives the source of funding, and gives the information from where the full trial protocol can be assessed. Strengths and limitations of this review. This review is a very well-written article. It fulfills all the requirements of the CONSORT checklist, except in results. For each group, it does not mention the losses and exclusion after randomization, together with the reason. And in methods, it does not give us the subgroup or the adjusted analysis. Thank you.
Thank you, Dr. Alishba. Nice presentation. You have appraised very well. It's covering all of the aspects. Thank you so much.
Should I end the meeting?
Thank you, Dr. Alishba. Very nice presentation. According to consort checklist, all points are covered. Thank you very much. Yes, please end the meeting.